Again, no, it's showtime. Thank you again for joining us for part 3 of Finding Positives. We're going to start today. This is, as many of you know, the third part of the series. Over the last couple of weeks, we've talked a lot about sort of the process of finding positives. What does it mean? What are the key components of finding positives, looking at the bigger picture, so to speak. Today we're going to talk about, go over a couple of terms and a couple of factors and issues that we talked about in part 1 and part 2, and move on to talking about best practices and what does it mean to implement effective HIV testing, or what does that look like? What are people doing around the country? What are studies saying? And what are potential lessons learned that we can talk about today and implement at our respective agencies? And taking into consideration a couple of the concepts that we have discussed, such as target refinement, identifying those structural barriers, and sort of unpacking what that means more so for our respective clients and target populations, and how can we use mapping information, or how have others used information from community observations. So in part 1, we started a conversation, and we displayed this slide, which essentially shows us what the impetus and the emphasis around finding positives with this statistic that tells us that about 25% of the population who is infected with HIV do not know it, and that this is resulting in about over half, approximately 54% of new infections. This is where this is the meat of it. This is the fact that starts indicating to us that yes, this is the problem. So what are potential solutions? And we've talked about sort of the barriers, the reasons why this exists. We said stigma, we said environmental barriers, structural barriers, personal characteristics, personal attitudes, beliefs, behaviors. We've been talking about this over the last couple of weeks. So now, today, we're going to try to focus more on, so what are potential solutions? What are people doing? What can work for us? As part of that conversation, we talked about sort of the strategy that has been pushing this forward, pushing this agenda, and identifying reasons why. Again, what is the relevance? Why is this so important, right? So we have here the National HIV/AIDS Strategy, which will have us complete these SMART objectives that you see here on the left-hand side of your screen, and tells us that hopefully these are the objectives we want to accomplish by 2015. Now, in terms of how we're going to do this, so the CDC responded with their little red book, or the document, High Impact Prevention, that tells us that these are the routes in which we're going to see this through. And that's going to be tackling and implementing enhanced HIV testing and linkage to care. Again, enhanced HIV testing meaning increasing the number of people who are getting tested who do not know their HIV status, testing people who haven't been tested ever, or testing people who haven't been tested in a year or two or more. There was also an emphasis on antiretroviral therapy, access to condoms and sterile syringes, right? Because it's not just about identifying those that are positive, but it's also about linking them to care and maintaining them in care. Again, you see here the emphasis of the clinical setting, the biomedical side, and that's where the changing landscape is moving towards. And finding positives, of course, is a critical component of that, that starts this process. Talking about prevention programs for serodiscordant couples, talking about substance abuse treatment, right? Again, looking at the bigger picture, looking at those environmental and structural barriers, screening and treatment for other STIs, because again, indicators tell us that areas or populations where there are a large prevalence or incidences of STIs can also indicate high-risk behavior, which can also lead to HIV infections. The use of PrEP and other biomedical options, and enhanced networks to facilitate housing linkages. Again, all of these factors, all of these components to be integrated and included in methods of high-impact prevention. Again, always keeping in mind maximizing limited resources, because that's really the name of the game here.
And what we talk about here, it's sort of like this is the focus of what is the combination prevention strategies, like Michael was saying, and starting with finding positives and then walking them through the potential different services, a combination of services that they may need in order to achieve that, if positive, that adherence to medication, that lower viral load, and at the same time, what we're talking about here is scalability, making it like broader. That's what maximizing limited resources is referring to in this combination prevention, whether with positives and or high-risk negative individuals.
And here briefly we have the Florida Cascade, or the Floridian version of the Garner Cascade, that really points out the service gaps. It really points out where we can intervene in sort of addressing high-impact prevention, and thinking about, in terms of thinking about the population who are infected. Approximately 20-25% who don't know it, or actually 80% who are diagnosed. Then again, right, it goes down, the numbers decrease in terms of those who are linked to care, and those who are linked to care don't necessarily stay in care, so retention in care again drops. Again, we want to get to the suppressed viral load. Why? This is why. This is what the whole Garner Cascade and addressing those service gaps is about. It's about getting people access to antiretroviral therapies. It's about viral suppression, because as we know, the more people who know their status, are linked to care, have access to the drugs, virally suppressed, the less the chances of transmitting the virus. And that's what high-impact prevention is really all about. That's what finding positives is about as well.
And this is also thanks to the research done, you know, and out of that research also came what we have as PrEP, but this is sort of like what treatment as prevention actually means, and it's, you know, the results that when a person who's HIV positive, viral load is to the point of being undetectable, less transmission happens. In conclusion, being that someone who definitely is in this sort of treatment, then it's less. I mean, it's less probable for transmission to occur. So. And again, it goes to the emphasis on why HIV testing, why finding positives, and why linking them to care. Because, again, research has proven that when this part here, when people living with HIV or AIDS lower their viral load to undetectable, in general, when we're talking about community viral load, then the lowest the level of HIV in a community, and then it reduces HIV transmission rates. So it can be in a single relationship individual, but if we talk about all these individuals who are diagnosed and linked to care and are retaining care, then this will happen. So that's the rationale also behind the National HIV/AIDS strategy that talks about linking a certain amount of people to care, finding certain percentage of those who are positive, because at the end it's going to reduce transmission and incidence. Are there any questions up to here? We're going to unmute the line so we can move forward with sort of like other components that we saw on day 2.
The conference has been unmuted.
Any questions so far? Okay, we'll be moving on. Thank you.
The conference has been muted.
Also, as part of that conversation, we have been talking a lot about stigma, its relevance. The National HIV/AIDS Strategy has really included topics around stigma into the strategy, basically saying, you know what, this is something that we know is happening, but not enough work is being done to sort of address the different types of stigmas in the community, to address these fears, to address these misconceptions about HIV. Last week we talked about sort of tools that we can potentially use in mapping stigma or identifying those indicators that are telling us a little more about our individual communities and what are the resources in those communities or not. What does our community look like in terms of structures, in terms of populations, in terms of who are potential gatekeepers that can inform us more so about the community, who can inform us more about those fears and those and that misinformation and that miseducation that's happening as well. So today we're going to definitely wanted to identify that, and we can certainly talk more about the tool for those of you who have any questions about it. But again, going along with stigma and identifying it as a major structural barrier in testing.
And part of also of the National HIV/AIDS Strategy paired with stigma is that component of education. And when we talk precisely about the different how structural barriers come in different ways, such as availability, accessibility, and acceptability, by doing this, by mapping not only stigma but also any other socio-ecological structure barriers, we'll be able to tailor, not only segment who our population is in terms of the influencing factors in the environment, community, social, as we saw it, and we're going to see it again, social, community, relationships, and the person, but also in terms of assessing how these play along in terms of their availability, accessibility, and acceptability to, in this case, HIV testing. And it's important because it helps us with assessing not only the needs from one person's perspective, but potentially of a small community. If the need is around food, then what does that mean in terms of partnership, and how can I address that in a way that also links to potentially my testing activities? And also, how do I bring in education around the topic, and how do I bring and how do I address stigma as well? It's sort of like it's good to know what are these different factors to be able to craft an implementation plan for our services, with the result being testing those who are most at risk, depending on our screening tools developed based on this redefined target population. So again, availability, if it exists, quantity respective to population, but that's very narrow. Another way of thinking about availability, and I explained it, is the different types of condoms out there. That is another way of showcasing availability, because it might be that that's not the brand that they want, so it's not available, or that's not the size that fits, so for them it's not available. So availability goes beyond just quantity. It's about specifics of what it's more, and again, goes acceptable by that, by their population. They will not wear it or use it unless it's specific. So if it's not available, or they cannot, or not affordable or accessible because of transportation needs, then it's not going to happen. So by doing this kind of mapping of the community that we serve with respect to all these different environmental barriers, then we'll be able to best craft or design our implementation plan, not necessarily our program, but our implementation plan of our HIV testing intervention.
Actually, in terms of the 3 A's, I mean, again, it's basically about whenever thinking about any potential intervention, how is it going to work, what does this look like, and how can we plan for it? And so in thinking about availability, accessibility, and acceptability really is going to be an indicator for us in terms of the effectiveness of any intervention that we're going to implement. And this was more about structural interventions, which we talked about in part 2 of the webinar.
Which HIV testing is kind of like a part of, as well as condom distribution. And this is also kind of like links to the bigger part, and we'll see it soon in terms of combination prevention. So, and the fact that there's a need to design and evaluate innovative prevention strategies and combination approaches. And what is meant about design is that we have kind of like these different tools provided to us by certain interventions as we go into, for example, the EBIs, which are behavioral, structural, public health strategies, interventions, but we sometimes have our sort of own homegrown interventions that can be part of this combination prevention, because it's about the customization of what best fits my target audience. If it's PrEP, and when we talk about PrEP, one of the questions before was about affordability, right? If we go to the 3 A's, it will be more of the accessibility or affordability, and that's something that comes often into our minds when we talk about PrEP. But PrEP per se, it's sort of like an intervention that has as a tool the pill, in this case, and a specific one used during the study, which is Truvada. But when reconsidering PrEP, we're talking about beyond just the pill. We know it's effective, but what are the guidelines around this? What are the behavior changes that need to happen to be able to, for example, adhere to this method of prevention? What does it mean in terms of still using condoms when on PrEP? Is this for a particular population, target audience, or if in general? Sometimes we just focus on the affordability part, but not necessarily the acceptability. Is it going to be acceptable? We're talking about, again, adherence to it. Right now, they're testing different periods, whether it's for every day, twice a week, once a week. Those studies are being conducted, but also there's a study being conducted in terms of implementation in a community-based organization setting that deals with these surrounding elements, because any type of combination prevention is going to have a behavioral component to it. If we ask about testing, HIV testing, the behavior is to, I have to go through that stage of change kind of process as an individual to first jump from the pre-contemplation to the contemplation to say, oh, wow, yeah, I'm at risk, and then the preparation, which can take some time, to the actual doing the testing. And we have to, again, consider the different things that happen and the fact that we may see HIV testing as a routine thing, but our target audience may still have that huge stigma to fear of the result, and so forth. And third, it might not be their priority. So it's a little bit of behavior involved in it. How do we deal with stigma? But this is what we're going to talk about. But this is sort of like the prevention combination, and it's about how to evaluate. And evaluate means like combining them and testing them with, kind of like our target audience on what we offer in our organizations and how can they link to each other. Screening is a big part, sexual health curriculum, the policy opt-out testing, and so forth. But we're going to talk about with some examples on this, right?
So in terms of looking at the combination prevention, right, it's all about looking at where we can have the most impact. What tools are we currently using? What tools can we use? Or what combination of tools are going to be effective for us? Again, we really emphasizing and underscoring the importance of customization, and really, any intervention that we are implementing at our respective agency should mirror the needs of the community, should mirror the needs of our clients, which vary, as we all know. It varies from community to community, neighborhood, potential neighborhood to neighborhood, right? And so it's really thinking about what parts of those of the prevention toolbox, what tools can I use or can we use as an agency, or can we use in collaboration or partnership with other agencies, right? There's certain tools that we have access to that we're currently implementing, and other tools where it's a little away from our reach. For example, CBOs, we do HIV testing at an individual level, but when it comes to treatment and providing ARV, that's up to for hospital settings, clinical settings. So we collaborate, we work together to have access to that other part of the tool, right, and really include it in this combination prevention. Points of contact. Again, in terms of thinking about our strengths as an agency, in terms of what is that we're doing really well in the community, how are we working with others in the community, this social ecological model gives us a route, a path, tells us, informs us a little more about where we fit in. Does our strength lie in more in the individual level, meaning changing or influencing the individual's attitudes, beliefs, knowledge? Does our strength lie in relationships, so in terms of accessing those social networks, those peer networks, those social interactions that are putting people at risk? Does our intervention is our point of contact or point of intervention more powerful or more effective at the community level in terms of changing social norms, in terms of addressing cultural norms, or at even the exterior level, societal level? How much, what are the players, who are the stakeholders, and how much of our work is being influenced at the policy level, statewide or government-wide? Again, these are just different points of contact where we're currently intervening or can intervene in the implementation of effective programming around HIV, specifically testing, that is, but also, again, looking at those different service gaps that are addressed in the cascade.
And this is just to also say that it's not sort of like linear from up societal all the way to the individual in terms of change, but it can be from within community and relationships towards the individual and back to change. It's sort of like, therefore, kind of like the circle of it, and looking at, again, the combination prevention that can impact, for example, if we do a social marketing campaign around addressing stigma and increase education around HIV testing, we might be impacting community. We might have an impact at a community level that may trigger down to a relationship level, that may trigger down to the individual level. When it comes to behavioral interventions now, that I think we're going to see one today about partners. then the relationship can influence then each individual, and or vice versa. We'll talk about an individual counseling session can influence the relationship and therefore the community. It all kind of like relates depending on what's the combination and the outcome that we want out of this prevention approach that we have with our target audience. And we may have that societal impact because it might kind of like generate that new behavior as a community, and the community then it showcases this at a more bigger level that may impact societal norms. So it's all how we approach. It doesn't necessarily have to be kind of like a policy level approach, because what we're here for is for HIV testing. But we can assess the community, we can assess how relationships happen, we can assess the individual and craft this combination prevention approach that could be a social marketing towards our testing program that addresses relationships, for example. So, and relationships in different contexts, not only from sexual partners, but at different contexts. But we're going to see that.
This idea, we talked about, we've really been emphasizing the idea of HIV testing as a process, and it's not just a task. It's not just something that people just naturally come in, get tested, and it's over. It's a process that's broken down into several components that we've been talking about: the environment, our knowledge, our attitude, beliefs, and behaviors that are influenced by gender, race, income, our needs, our priorities. Again, strategies, customizing potential interventions that address these points of contact is what is an integral part of, an important part of finding positives about this comprehensive and integrated process.
And this just says HIV test, and here that's kind of like an example, but we can use this sort of like to have that combination approach. Remember, a lot of the different things I understand we are, in a way, moving from the diffuse effective behavioral intervention, but they're still part of it because behavior has a lot to do with, you know, the outcome of this. Sort of like if we want someone to adhere to medication, behavior change needs to happen. If we want someone to do an HIV test, there has to be some sort of behavior change. If we want someone to keep using condoms, still a behavior change. So, you know, in thinking about, again, combination prevention, we cannot just kind of like leave behavior out because it's part of it, but it's sort of like this, the formula that we saw that precisely this behavior is a function of individual characteristics and the environment. So how do we address all this and thus change kind of like that behavior? And again, we mentioned that all these different things are very specific to the different individuals, though many different things can impact our community as a whole, but how we experience it as individuals are very different. It's sort of like what we see here, this kind of like circle of determinants of health that go from the social-economic status to geographic location are very individual, and I mean in terms of how they impact us, but are very, it can be also broadened in terms of how it impacts on a specific community or on a specific target population, and thus that the encouragement of doing this target refinement, because you know we might address, for example, homophobia because the way the community is being impacted because of their sexual orientation, and thus resulting in a specific behavior that has a specific health outcome. If it could be the socioeconomic status and not necessarily the sexual orientation, or it could be a combination of both in terms of community. So it's important for us to be able to use this graph and map out what we can do to impact these specific barriers, or who can we have as support in terms of partnerships. And partnerships are not only, again, organizations. They could be individuals from the specific network that let us kind of like navigate the network, give us access to communities and so forth.
So now we're going to talk about, that was essentially a review of part 1 and part 2, and specific components and factors that we've been talking about and wanted to expand on a little more. Now we're going to talk a little more about best practices for HIV testing and high impact prevention. And these are essentially models. These are based on experiences in the community. This is recorded data that's talked about effective interventions, how they've worked in the community, and the specific communities they have worked with, just to give us an idea about interventions, give us an idea about strategies and methods that we can implement in our daily work. Or also, if these practices or strategies can't literally be mirrored at our individual communities, what about these models, or what about these best practices can we use, or can we mold and can we customize for our programming for its effectiveness in producing more positive health outcomes, starting with getting more people to get tested for HIV. Here we have, this is a study that was sort of looking at the feasibility and acceptability in terms of one of those the three A's, the acceptability of door-to-door rapid HIV testing among Latino immigrants in terms of getting them to get tested for HIV and know their HIV risk factors. Now this particular study is from North Carolina, Durham, North Carolina to be specific, and there's not a lot of literature that talks about door-to-door interventions. Again, when I hear door-to-door, and when many people hear door-to-door, your first thought is that's difficult, that's not going to work. Stigma, fear, that's invasive. That doesn't respect people's privacy, et cetera, which is a very, very common thread and idea. However, there is literature and there are examples of this being utilized, of this tactic being used with specific communities. And I think it's really important to look at, well, how was it used, and what was these communities' response to it. So here in this graph we have the study was broken down into 15 outreach events. Now these events happen in terms of, for those of us who want to know more about methods, we're methods people, it was on Saturdays. These outreach events occurred on Saturdays. They targeted apartment complexes with that had a large population of Latinos. Now, many of these Latinos were immigrants. The average amount of time that they've been in the U.S. was about 5 years. Okay, so this is certainly specific to this population. And these outreach events happened. There was about 15 of them. They reached out to about 333 people. Now, the criteria to participate in the study and to be included was you have to be over the age of 18, not pregnant, and reported no HIV test in the previous months. So of those, about 315 people were actually eligible of the 333 that they contacted. For those people, what I really want to point out is that they were given a survey and also they were offered free HIV testing. 175 consented to the survey and HIV test. This is about close to 93% of the population said that they would accept the test based on the fact that it was door-to-door, and that they actually saw it as an acceptable form of outreach. What this also points out is the acceptability, but also the predictors of testing.
But and before we go on to the predictors of testing, one of the things again to remind how we started these sort of webinars of finding positives. One of as you see this eligibility and the eligibility concept, and though it's sort of like broad here, like 18 and over, not pregnant, reported not having had a test in previous months. It's sort of broad. It gives us still the concept that of this kind of like redefinition of who is our target population. Not to mention that there were also from Latin origin, and I think low income housing units, and sort of like that provides us kind of like this concept of not only who our target population is, but having like lower income housing units. That provides us some context in terms of the environment and the influencing factors maybe to not have accessibility to an HIV testing. And one of the feasibility can be translated to affordability or being able to pay for it, right? Or so, you know, it's a clear example on how redefining who our target population is and how do we kind of like craft our outreach approach come together in terms of who they are, what are the structural barriers, what can I do, and see the results.
And one thing I definitely wanted to point out is that the people that were conducting the outreach were promotores. And promotores are community health workers. The community health workers, lay workers, are essentially trained peer educators that were conducting the outreach, that were conducting the surveys and the testing as well. So again, to sort of think about getting us to think about what do we have access to now? What do we have implemented? And I know many agencies have peer educators that we use, and this study uses those peer educators. You know, certainly trained the peer educators to do the specific type of research. However, peer educators nonetheless, who were able to tap into these particular networks, who were able to impact or integrate and come into these networks to find these people many people who haven't tested before. So again, just a talking point in terms of getting us thinking about what do we have in place now that we can potentially modify and use to our advantage in a way that perhaps we haven't before.
And it's another concept that sort of like comes out. It's sort of like that relatedness and trust when it comes to having these type of conversation around HIV, around maybe sexual practices, in completing a survey and so forth. So it's sort of like that connectedness and that trust that potentially these peer outreach workers provided or brought in these efforts. So when it comes to the predictors of testing, and again, we talk about the perceptions of being at risk of HIV. So that potentially occurs while having this sort of like education component within our intervention around HIV that brings the person from a pre-contemplation stage to a contemplation, and that's kind of like perceiving oneself to be at risk. So that's, again, when we bring back these theories that we've used in behavioral change, effective behavioral interventions. It's some of these theories combined. Many of them have these stages of change or trans-theoretical model of not considering to considering it to considering it. So that's the first that we have here as predictors of testing. And I think we know this, if you don't perceive yourself at risk, why would I get tested? And again, compared to that is no history of prior HIV testing. Maybe the reasons might be that they were never offered. Again, if we go back to the name of the study, feasibility and acceptability, and if we go back to who our target population is, then either they never consider it, or they never were offered, or they didn't know how to get it, or they couldn't get it. So again, it goes to acceptability, we go to perceiving, it's the acceptability part. The no history of prior HIV testing could be the feasibility or accessibility to it, like being able to get it. History of ever having sex with a commercial sex worker. And again, this is sort of a topic that might have been part of the survey in terms of what changed that perception of being at risk. Was that the trigger? That, that want HIV is not only within the MSM community, that it does happen within heterosexual relationships. So it might have been this. I think we have a little bit more information, but I'm just, based on just these predictors, what can we sort of like assume right now? Ever having sex in exchange for drugs or money. So we, in our kind of work, we know that a predictor, it's sort of like this, and again, it might be the other influencing factors. Why exchange for drugs or money? If it's for money, it might be kind of like inability to find a job, maybe other needs to support yourself. It might be for continuing a habit of drug use, so it might probably the behavior change needs to occur in terms of using drugs. What are those drugs? But if we see here, everything, it was around sex. It's not around harm reduction for drug use, but it's around sex. Living with a partner, and reported alcohol consumption, and multiple sex partners. So this kind of like predictors, it's sort of like guide us in terms of, okay, maybe developing our screening form to be able to say, okay, if this person responds to this, and maybe they don't perceive themselves at risk, then and they have engaged in this, then it's someone that I should offer a test.
And one thing I wanted to point out before we move on is also in terms of looking at the predictor, and again, we're talking about this specific pool of people, this specific pool of study participants. The predictor that weighed heaviest in terms of increasing the odds of people getting tested was ever having sex in exchange for drugs or money. So for participants who said yes to this question, were certainly more open to getting tested versus the participants who were currently living with a partner. That was the opposite. Those were the participants or people who did not accept HIV testing or had never been tested. Again, with this perception, it's all about perceiving oneself at risk, that it's ideas of relationship, trust, communication, and we're going to talk a little bit more about that and sort of how these interactions, how these interpersonal relationships are being talked about in current interventions. But the chances of, or the probability of living with a partner That's less people getting tested just by that fact alone. And so that gives us an idea of, well, what does this mean for us, or how can we use this information in targeting, in doing outreach, in redefining our population.
And it's interesting that you bring this point, because remember, one of the initial ideas that we came with in terms of redefining a target population, we described an individual who was having unprotected sex, but it was about monogamy. So, and a lot of the responses were, well, maybe you don't know what the partner is doing, maybe this person. A lot of the responses from that initial webinar was that this person was most at risk because the issue of the relationship, not knowing what the partner was doing, assuming monogamy was happening. And one of the things that comes into the redefining who's the population at risk, we not only need to consider the network risk or the pool, but also one of the things were the relationships, right? The relationships, and if we're talking about when the couple decides not to use condom, how is this monogamy ensured or understood? What's the communication? And a lot of the things one may not, if they don't consider themselves at risk because of the concept of relationship, then we might need to kind of dig a little bit more in terms of what this means, and maybe have a different kind of approach in terms of healthy relationships type of intervention. And I think we're going to talk about one of them in terms of testing and partner relationships. So the acceptability of rapid testing in the community, again, keywords here, a lot of these different things are using the 3 A's in terms of reaching out to the community and in crafting their approach to different interventions. So one of the things here that works with the norms is precisely whether I accept this type of intervention or behavior change. Do I want it? So, and it goes with condoms, and it goes with, adherence or taking a medication. It goes with different things, the acceptability. Like, in other words, I accept this and make it part of my life, I'll say.
And also taking into consideration, again, the point that I highlighted, that this intervention was being done by peer educators, right, people from the community. And with this particular population, Latinos in this community, there is, in terms of looking at cultural norms and cultural scripts, familismo, or familiarity and respect, there's certainly high levels of respect and familiarity whenever there's a member who we identify with, or who Latinos identify with in the community. And especially when we're bringing information, thinking of access, barriers to care, not having insurance, being undocumented. If you have a representative from your community who also is of a similar experience, it opens up that door to have that conversation and to unpack a little bit more of those misconceptions. So again, because they were peer educators, because they were representatives, from the community, this allowed to have that type of interaction, facilitated those conversations. In terms of other factors that made it feasible and acceptable, the idea of testing inside the home or in the general community was preferred over other locations. Again, that fear, if I go to a clinic and I don't have papers or I am undocumented, I can be potentially compromising myself. But having the option to have a representative from my community come to my door and talk to me and tell me that, no, that's not the case, that doctors and healthcare workers do abide by confidentiality and will respect my confidentiality. Those pieces of information and those points of contact are key and can be used in implementing these types of interventions. Certainly, it's important to know the differences in the preference of HIV testing sites, and that these differences can exist between different racial and ethnic groups and communities. Again, having to do with reasons of knowledge or familiarity and trust in healthcare systems. For example, a contrast study said with a study that also looked at HIV testing preferences among a predominantly black female population in the Housing Authority in Chicago, found that most preferred to go to a primary care clinic and multi-specialty sites for HIV testing instead of community centers, right? Again, you have a different population with a different perceived notions of risk, different priorities, different experiences that tells them that they would rather go to a community center, right, where they see, there's knowledge there, there's expertise there, where the person coming to the home is not necessarily the best practice or looked at favorably, right? So again, it's really important to look at these differences in terms of communities because, again, customizing what best practices is going to work for the communities who we provide services to.
And one of the things, and this is what another change comes into play, is sort of like the Affordable Care Act, and how it impacts affordability, potentially accessibility, but does it impact acceptability? Am I someone who is used to seeking routine medical services, or am I someone who, because of my cultural experience, because of my perceptions and beliefs, I only use this sort of system when there is an emergency? And this is sort of like what was or is happening, or sort of like conversations that we've had here, is that Latinos tend to test late, so they usually dual diagnose with HIV and AIDS because it's at a point of an emergency that maybe an opportunistic infection or something happened that they found out that they were HIV positive, and at the same time they have developed AIDS. So we have to kind of like, again, in our assessment, address this kind of like acceptability, accessibility, affordability, what is preferred, as we see here, trust, again, it's mentioned, familiarity, while others accept more of a health setting clinic. Maybe it's around because of confidentiality, and others believe their particular home are confidential enough space to have this type of intervention. And also in this particular case, the misunderstanding of how the healthcare system and eligibility, and I think Michael just explained that, but how, imagine now, and when this was done, imagine now that this is coming in terms of the Affordable Care Act. Many will be in this, others because of and yet another influencing factor that it's the immigration status may not be able to still access this yet. They might be part of that network pool or that relationship that impacts one's potential behavior and thus a health outcome.
Okay, so here we have, we're going to address another population. So this study essentially saw that a fifth of gay men in a relationship with an HIV-negative male partner have not had an HIV test while in their present relationship. Again, so this is more so people in relationships, living partner. The study found out that the factors associated with not having a test included younger age, lower levels of education, having a sexually closed relationship, and a greater level of trust. So in terms of the background or context for these types of studies, which also mirror current trends in terms of the disproportionate rates of HIV in different communities. So previous research tells us that between 33 and 66% of HIV infections among gay and bisexual men in the United States are transmitted within the context of a primary relationships. So a lot of infections happening in relationships. This is, again, one of those point of contacts that we can address and intervene in constructing effective interventions.
And this part of the population, may not, because of the concept and notion of a close relationship, again, affects the perception of risk. And then it would be something in terms of an intervention to think what would be a trigger to go from that pre-contemplation to contemplation stage. And maybe part of the screening might be, what does a close relationship mean? And what are the type of conversations happening between these couples and relationships that can be transformed into a message in a social marketing campaign, for example, targeting to young couples who are in these close relationships that are driven by trust, for example, and using this information to kind of like impact or become that trigger, at least for them to get tested, because it should be part of a kind of a routine eventually for this behavior to occur, and that's something that we can also consider. We have a different example here, talking about specifically MSM, and with seeing the factors associated with not having a test. So immediately, this population, as soon as they enter a relationship, testing is not part of that equation. So how can we impact this with our population to make it a part of it, and still having them both consider that that this is something that they should do and continue doing until maybe that conversation around what close means and that trust it's totally understood between them.
So in looking at information that talks about relationships, it's really, as providers, it brings up the question of how are we talking to people about their relationships, and what are really in that potentially that screening process or in the risk assessment, how much importance or how much time or how detailed are people being about their relationships, or how much are we probing? And again, it varies from agency to agency, but it really just brings up the question of, how are these relationships being talked about and addressed, and really the dynamics of the relationship, but again, also the dynamics in the relationship in the context or environment that are supporting these relationships, that are surrounding these relationships. In terms of looking at, again, this study with gay men, or MSM, it looked at these characteristics. It looked at the duration. So essentially, compared to other testing groups, men who had never tested for HIV were younger, had a shorter relationships duration, had lower levels of education, and were less likely to have an agreement about the sexual parameters of their relationship. Men who had never tested also reported higher levels of commitment to their relationship and greater degree of trust and faith in partners. So just these ideas of communication, trust. Now, these are concepts that, for some, they're solid. We know what trust means. We know what communication means. But for others, these are subjective terms, and I think that's really the nature of relationships, is that what I think or what I perceive and think is monogamy or monogam-ish it can be completely different than my partner's. And it's in those differences where people can get in trouble. It's in those differences, when not discussed, that there can be points of contact or points where we can intervene potentially as providers, whether that's with information or guidance, providing a space to have these discussions, or probing as part of our screening processes. How are we probing? How are we asking and talking to people about their relationships, especially in the context of MSM? Looking at the rates, looking at the disproportionate rates among MSM of HIV, with HIV, and the fact that, data shows us that a lot of these infections are occurring within the context of a relationship, right? Again, it's not about its behavior, but it's also understanding the behavior in the context of the people, the dynamic, and the environment. But at a minimum, it's how are people communicating? And those are points of entry, points of interventions that we may have influence over.
And I will also extend this communication to the service provider and how this communication is also happening in terms of probing or having some questions around, for example, what's these permitted sexual behaviors that happens in these maybe open relationships. Again, and some of the things may be an issue around also trusting the service provider and being able to express what are the different arrangements that you have or the population has when it comes to relationship, or my client has when it comes to relationships. Am I going to be, and this is what we sort of like when motivational interviewing comes on board, and how we are perceived by our clients when we provide these type of services, that we usually get the answers that they might believe we're expecting to hear, as in, I always use condoms, or I always, I'm monogamous and have my partner who is monogamous, and yes, we've had this communication, but what does that mean? Sort of like, or maybe it doesn't even, it's the right, not the right answer, it's not what's really happening. So it's sort of like, how can we navigate? And this is part of sort of like, again, the screening, it's part of, motivational interviewing, it's part of our approach, it's part of developing that trust, it's part of that communication as well, and being able to help the participant or client navigate through these concepts of relationships and sexual agreements and risk, to be able to then, again, reach a trigger. And a trigger, it's individual. I mean, it happens differently for everyone. So a trigger that is going to lead me to preparation and action, which is actually the testing part of it, and so forth, in terms of my continuation in care, my adherence, if it's on one, if it's working with HIV positive individuals or found positives, and or with this sort of like combination prevention for high risk negative that may be impacting, for example, communication, may be impacting, what these sexual agreements mean, may be impacting, trust, and may be impacting behavior. It's sort of like, this is what it's encouraged to do when kind of like assessing or when finding who is this redefined target audience. Are there any questions until now? I'm going to unmute the lines.
The conference has been muted. The conference has been unmuted.
Or any questions or comments, experiences?
The conference has been muted.
So in terms of looking at these dynamics, so we've been talking about understanding or trying to understand the dynamics in relationships and how this leads people or can put people at higher risks without them knowing it. Or the decisions we make while in relationships, or specifically decisions that men in relationships with other men or in sexual relationships with other men make. What are those decisions based on? What are those dynamics? And how are they potentially putting people at risk? Now, there's this new public health strategy that is being rolled out by the CDC, and it's couples HIV testing and counseling that is meant to provide, it was meant to do many things, but one certainly to provide that space for couples to have those discussions, to understand those dynamics, to understand those sexual agreements that we referred to earlier. And in couples HIV testing and counseling, I mean, we know that few prevention efforts have focused on the couple or partner relationships. And again, in discussing or talking about couples HIV testing, the CDC makes it very clear that a couple is defined by two people. So really what they mean by couple is two people who are having sex and are together and are potentially putting themselves at risk. It's very loose and it's subjective. It's whatever those two people, however those two people identify themselves, but it's really any sexual relationships. It is not two people, for example, two friends coming and get tested together. That is not what this intervention is meant to accomplish. So I just wanted to clarify that. But in terms of looking at this intervention and it being a prospect and a strategy that we can potentially implement as providers, it reduces the burden of sharing one's HIV positive status by ensuring provider-assisted mutual disclosure. So you have the provider, you have two people getting tested, and the provider is providing information, support, and guidance through the process to both people, which can be very, very effective and useful when working with couples. It creates an opportunity for couples to discuss, establish, or revise sexual agreements for their relationship. So again, it provides a space to talk about, well, what do we mean? When you say monogamy, are we both in agreement with monogamy? Are we both in agreement with the parameters that we have set, the boundaries that we have set for our relationship? And the intervention, again, creates that space and supports that space to have those conversations, to really start unpacking and identifying the things that are potentially putting couples or people in relationships at risk. It allows couples to prepare a risk reduction plan based on the HIV status of both partners. Okay, so you have buy-in from both sides. Provides a built-in support system which may aid in linking persons living with HIV to essential care and treatment services. Now this is specifically very, very particular to discordant couples, where this sense of support is very important, where the HIV negative partner can be a source of support for the HIV positive partner, and what will be their agreement to move on. What will be sort of, again, the boundaries, what will be the understanding for that couple to move on, and how can one support the other in terms of treatment adherence, linkage to care, maintenance and care, and be a backup, and be a support for the other partner. And again, and also talk about the sexual negotiations and how how both partners are going to talk about keeping each other safe in this serodiscordant relationship. It supports pre-exposure prophylaxis, or the use of PrEP, and condom use, which can help prevent HIV transmission. So again, serodiscordant couples, usage of PrEP. This is another space where couples can talk about PrEP and how they're going to use PrEP as one tool that's part of the toolbox, right, the HIV prevention toolbox. And another important note is the early diagnosis of HIV infection and linkage to care. Both partners coming in, knowing their status. And again, and what I like about this intervention is that it certainly has three main scenarios. So it's delivering serodiscordant, delivering, so either both are negative, both are positive, or one is positive, one is negative, concordant. And so how it talks about how, as a provider, as a counselor, what would be the messages that you would be delivering, the education that you would be delivering, and how so in the context of talking to two people. Again, because this is being done 3 people in one room. Okay.
And the reason why we wanted to sort of like give you an overview of this intervention is, again, to think about what we started, and this is kind of like going along the lines of the operationalization of HIP in terms of redefining our target population. Are we reaching couples, right? Or what parts of these, as we again mentioned, people who are at high risk might be in relationships that are sexually close between quotes. There's level of trust in such relationships. We talk about the characteristics of it, and sort of like this is kind of like part of that. It's a network risk. Again, MSM. We're talking about MSM risk. It's about the specific relationships, and this is something that we can use in sort of like developing either our material. If that's our target population, it can be something that we use in terms of our assessment, initial assessment, in the redefinition of who's our target population. Are these part of kind of like these predisposed characteristics in terms of my persona, who's my target? Is this part of kind of like the knowledge, attitudes, and beliefs, and the knowledge that or beliefs or attitudes clearly defined in terms of what relationships are, and therefore it must be, the belief is that they must be safe, and so forth. So it's sort of like an example on what can we take from what this intervention is doing and use potentially in our assessment, in our screening, and also our in the ways that we reach out to the population, whether it's through a social marketing campaign, whether it's through our flyers, that creates that kind of like click, again, that trigger for from the not considering it to considering it, even though I'm in a relationship. So it's some of examples or lessons learned. If this has come out as an intervention, it's because what we've seen before in terms of this, how relationships impact that perceived risk in the individuals.
Now, oftentimes people ask, well, what's the difference between couples HIV testing and counseling and individualized CTR? So I provided this slide here, and again, all this information can be found directly from effectiveinterventions.org. So you can certainly get more information there. But I just wanted to provide this and just point out a couple quickly about the utility and also the how it can be advantageous for providers to use CHTC as well as CTR. So CHTC is for providers already conducting CTR, HIV CTR. So it's another tool. It's another tool that you can use in testing strategies. So one of the things that separate it that I'm going to point out quickly is this idea of, again, creating a safe space for having complex discussions. Again, people get to talk about their sexual agreements. People get to talk about what, how they see the relationship, what are the boundaries, and make sure that that both partners see it the same way, right? And whenever there are these tensions, whenever there is difference, then and assuming that the difference has to do with protecting yourself or putting yourself at risk for HIV, then that is discussed in that forum, in that space. Again, another critical component of CHGC that is different about individualized CTR is that it is tailored. It is tailored and customized to that relationship, to that dynamic between those two people. And in talking about what are the factors that are putting them potentially at risk, or what can they do, right? What are they doing that's not putting them at risk, and what are they doing that best practices that they can continue to take on and to move forward with to make sure that they both stay healthy. Okay. So those are just a couple I wanted to share. And you can definitely explore more on effectiveinterventions.org in terms of potentially thinking about this intervention for your respective organization. Here, I will also be just straightforward. It was based on a different study that looked at decisional balance, and really fancy word for what are the pros and cons of deciding to get tested. And what the study found out was that more so in this, again, specific population, this was about 1,500 people who were surveyed, and what they sought out, what they found was that people in this pool tended to have more pros than cons to get tested. And in terms of those pros, or in terms of those reasons why they were getting tested, there were three main concepts that sort of were underscored, and these were the security and responsibility. So really this idea of, thinking about that everybody should get tested, HIV should be universal, or anybody who is concerned about their health, and you should know about your health, you should get tested. So again, these ideas were really acceptable and really accessible within this pool of participants. Also the idea that taking the test would give you a sense of security. I know my status. That gives me comfort, because then I know what's the next move. What other decisions can I make to make sure I stay healthy, or that I am healthy. Again, stay healthy, security for my family. So these prevention of transmission, right? So taking care of, I want to make sure I know my status so that I can also protect my partner, or I can protect any potential people I have sex with in the future. And availability of medication, right? The idea, okay, get tested, know your status. If it's a positive result, then I want to access medication as soon as possible so I stay healthy, right? And so those, in this study, those weighted heavier than the cons. And the cons, again, not surprising, preferring not to know, these ideas of fear, that are informed by stigma of being positive, and ideas of potential rejection from my community, from my family, from my social circles, and even still some fear of needles, where there are many, even though rapid HIV testing has been around for some time, people don't know that is an option. I know myself that as a ex-HIV tester and counselor, I experienced it a lot, where people were still didn't know that HIV can be a 20-minute test, can be an oral swab, and can be close as accurate as a blood sample. But again, these are points of contact. These are points where we can intervene, and it's just an issue of knowledge and education. So in terms of looking at other models, we're going to be straightforward, looking at being comprehensive. We talked about the cascade. We talked about identifying service gaps. we talked about how finding positives is a comprehensive process, from finding those undiagnosed and getting them to, along that process, to viral suppression. Following that model, there have been there's been success with this TLC, which is test, link to care, plus treat. Certain components of this model, it's been being rolled out in several jurisdictions across the country, but the information that we're going to share is data from DC, Birmingham, San Francisco, and Los Angeles County, and their success with TLC.
And one of the things that I wanted to say is that although this is kind of like being tested as an intervention, this is what we are to do. We are to test, link to care, and then the plus treat is what's sort of like going to be explained, and that means sort of like the beginning of antiretroviral, supportive retention and care. But a key component of this, and it comes out in this intervention, is the testing part, which is what we are doing, what we are looking to do, the finding positive part. And the test, and the way that they define under this intervention, it's called an increased targeted, keyword on targeted HIV testing. And when reading this, targeted means, again, who is, a redefined target audience. And I usually bring it as thinking of advertising and how advertisers do this market research and how they can pinpoint and create these different sort of like announcements so you can come into their market, and how they put it on a specific time slots in terms of the viewing audience. If it's something for women only of certain age, and they would put it on a specific program, or on a specific radio program, or internet website, or application. So, and again, when we talk about targeted, it's what we've seen throughout these webinars, this redefinition of who my target audience is, what are their needs, how can, in collaboration with others, assess these needs, and how can I move them into this potentially pre-contemplation, contemplation, or action stage to actually getting tested, because they might be in a planning stage, which is the acceptability done, but there's no availability or there's no accessibility. So again, as we've seen here, some of these interventions are addressing affordability and acceptability.
So, components of successful TLC Plus that we've seen across the country in terms of using this model, increase HIV testing, really increasing the opportunities for people to get tested, which this includes routine opt-out screening in clinical settings, and screening in non-clinical CBOs, again, addressing who's the community, what are their preferences, door-to-door outreach, community outreach, mobile units, going to them, or would they rather come to us? And that is, again, it's a piece of just understanding and knowing the community and redefining the population if that is the case. Using targeted social and sexual networks. So social network strategy has been successful in certain areas. I know SNS has received some criticism from different regions who have implemented the intervention. But again, it's all about who is the population and how can you customize tactics from SNS to work for you and reaching high-risk populations. And in this idea of improved linkages to care or streamlined linkages, which is essentially getting that person, the individual, the client, into care and retaining him in care by addressing the needs, by addressing those barriers, those structural factors, those personal characteristics that we have discussed. So one thing that I wanted to point out was this youth-focused linkage worker. Again, that for those of us who do work with young people, assuring or sustaining and really underscoring the importance of the training that it takes to work with this particular population, especially when it has to do with newly diagnosed cases, or those of us who work with in transitional housing, or with persons who were incarcerated, these ideas of jail-based transitional case management and peer navigator programs that we already may have implemented as providers, or can use as a point of referral to refer in or refer out. And the peer navigators and the education that we can use or knowledge that we can disseminate for those particular populations. Now, here we have, we talked a lot about, webinar part 2, we talked a lot about social determinants of health, structural determinants, and in the TLC study, based on information from like Ryan White and Linkages to Care, they resulted in identifying predictors of detectable viral load, right? The goal is always undetectable viral load once a person is on ARV. But these predictors of detectable viral load, again, just really inform and underscore those social determinants, or these disproportionate rates of HIV in communities, these inequalities in the communities when it comes to health. Looking at homeless or transitional housing, again, living at or below the poverty level, not having health insurance, history of incarceration, and the specific target populations, African American, Asian Pacific Islander, or Latinos. So again, looking at those who are affected the most, looking at and understanding the determinants of health, those structural factors, those environments, and using this information to really work more towards customizing our whether outreach efforts or customizing linkages to care or other modes of high impact prevention.
I think what we can deduct just by looking at this is sort of like maybe accessibility and affordability, poverty level, homeless, not having health insurance, recent history of substance abuse. It's more sort of like a specific behavior of this target population based on these, other factors as well. However, we cannot necessarily deduct what's the acceptability of it. So it'll be interesting to figure out and find out the acceptability of, well, if there's no accessibility in terms of antiretroviral medication and so forth, then these may link directly to sort of like a detectable viral load. And what are the different factors to affect this behavior of adherence? Again, we go poverty level, not having health insurance is one, but that's sort of like going to change it. And it'll be interesting to see what these predictors now, if they change, if they remain the same. And again, this may have to do with not necessarily, again, affordability or accessibility, but maybe acceptability of having these, routine doctor visits, having to have ART and adherence to it, and so forth. So throughout this time, we have talked about what will be sort of like combination prevention. We, again, as when we started these webinars, there's not a specific formula that will kind of work across the board. There are formulas that, we kind of like address individually, like the fact that behavior is the result of the person and the environment, the interaction of the environment with the person. We kind of like went more specific about the characteristics of who is this persons, like, and what's the environment that puts them at risk. So that's the broad formula, and from that we saw examples of how we can come up with different target populations based on our contracts and scope of services. However, we have to pay attention to also the structural barriers. And furthermore, although segmentation can lead to having a very specific target population, we have to come back and see what's realistic. And this is when the SMART objectives come into part. I create objectives of reaching on a specific population, and sometimes we have help or sister organizations in reviewing their SMART objectives, and they might say that they want to reach 1,000 gay or bisexual Latino gay men in a specific area, and it's not realistic because there's probably not 1,000 gay, bisexual, Latino men in that area. So we have to think about what's realistic based on this redefinition of our segmentation. Who will I need in terms of partners for this? And what combination prevention will work sort of like for my target audience? And what do I have in my organization? And what do I have from other partners? My goal is HIV testing. Of course, it's about linkage to care, but HIV testing goes with the screening, maybe some education around such sexual curriculum, addressing stigma in a community, linkage to care is the treatment. So how do I navigate? How do I create this that I can then help my target audience navigate as well? And as we saw at the beginning, we do the testing because of our screening and our segmentation. We define them either as high-risk negative, and then we have this combination prevention toolbox broad, that it's all these different behavioral interventions, biomedical interventions, individual interventions, and if it's positive, the individual, then we have these different kind of behavioral, individual, community, and biomedical interventions. So,
and really just going along with what Bolivar was stating, it's like, finding positives is not about this magic formula. It's about customizing efforts. It's about seeing what we're doing now and understanding it more, understanding opportunities for growth, understanding our strengths and what we're doing really well and how we can enhance that even more so to not just test, not just find, of course, which is certainly key, critical, integral part, is to find those undiagnosed persons. But it's also the follow-up. It's also the linkage, the maintenance and care, and making sure that they have access to healthcare, continuous access to healthcare, and to try to limit those barriers. That's really what Finding Positives is all about. It's that comprehensive, holistic process. And these are just a couple of things to think about. Really is, what does Finding Positive look like for us in terms of target populations or retargeting population or refocusing on the population with a different emphasis, right? This is all based on indicators. This is all based on the information we know about our population or the information that we can still collect. What information can we still collect about our population to inform our strategies, to inform our outreach, to inform how we market to them or how we disseminate information and strategies to the community to get them into that chair to test or into that clinic to test. What does Finding Positive look like in terms of recruitment and retention? Again, looking at internal processes, looking at outreach venues. Can those potentially change? What would that look like? Are we, again, reaching out to the precise population that we want? Testing, linkages to care, what does that look like, the current linkages to care? How do we see those through? Who are we working with? Through what collaborations and partnerships are we working with to see those through, especially if we are a community-based organization with no tie or no in-house medical setting or medical resources or clinical resources. And again, taking into consideration health disparities. What are the disparities that exist within our communities, within our clients? and really how are we addressing those multiple and competing needs of the client to get them in to test or to help them understand the importance of testing and of staying healthy. And along those lines, it's really thinking about what does testing look like now. And I really encourage, we've done this practice in several trainings with different providers, and it's really, really fascinating, and always usually a very fulfilling process to see staff members, to see testers, counselors sit down with managers, supervisors, sometimes even executive directors, and really brainstorm and really think about what does testing look like now. With this, just thinking about testing specifically, what does testing look like now for us? What needs to change? If there's anything that needs to change, what needs to change? How do we identify those factors? How do we start talking about those factors? And ideally, what would that change look like? So I really do encourage providers to have these brainstorming sessions across the board with different departments or different players, different stakeholders. Because you're going to have different perspectives, and it really informs, you really collect information about tactics, strategies, and how to potentially enhance on those strategies. And what changes, if assuming changes need to occur, what changes can we make to address this issue of finding positives? What tactics, what strategies, and how are we informing these strategies? What indicators, both data indicators and physical indicators, are we using to inform, to influence, to construct these ideas and these potential new interventions and ways of conducting outreach and testing? So we just wanted to close with those ideas, and I definitely want to open it up to participants to see if you have any questions or comments.
The conference has been unmuted.
If you have any questions or comments, please feel free to respond via chat option or over the line.
This is sort of like we've reached the end of this three-part series on this curricula that we have named Finding Positives. Again, different components, and as echoing was what Michael was saying, my main word in this series has been or is holistic. When having that holistic approach and thinking of testing or any other program that we do as not only a task-oriented, but it's sort of like a process, we'll think what are the different needs that we need to have in order to achieve that task. Sort of like, what are the skills that I need? What are the different partnerships that I need? Who is my target audience? How am I going to achieve this? And what's my ultimate goal? So, and with that, we are here to assist as a capacity building assistance program. We are here to provide individualized coaching. We can review your screening forms. We can review your protocols. We can review your recruitment and tactics or your social marketing campaigns. We are here to provide that assistance to all of you, whether it's as a group as we had this time and or in a very more tailored way for a specific teams or organizations. And with that, and in closing, I'd like to thank all of you for having been with us these 3 times from September 4th, which was our initial webinar last week, and today. It's been a great experience, and we hope we have provided you with enough information and and sort of like a process on how to go about defining target populations, bringing in the external factors, what is a combination prevention, some examples, and what you can potentially create and do for your specific programs. So thank you so much. You will receive an evaluation specifically to your emails of these overall webinars. I know the service has a small evaluation, but you will get one that is about these 3 webinars via email, as well as all the information and copies, attachments of these different articles that we've used to provide this webinar. It's been, again, a pleasure to have you during this webinar. And if you have any questions, here's our email, civadivision@latinoaids.org. Feel free to email us. We're happy to respond.
Thank you again for your participation.
Last but not least, these 3 sessions have been recorded, so we will have them available for you if you'd like to see them again as refreshers, or for your teams, or for those that weren't unable to participate this time. And with that, thank you so much, and I hope to hear from you soon. All right? Bye.
The conference has been muted. Thank you. Please stand by.